I'm working on a project that looks at the controversy over the diagnosis and treatment of children with emotional and behavioural disturbances. And this is motivated by the large increase in the diagnosis of mental disorders in children and the treatment with medications, particularly different kinds of antipsychotics, mood stabilisers, stimulant drugs and antidepressants. So in this project we looked at 3 case study conditions: ADHD, depression and bipolar disorder, and probably the most controversial of those was bipolar disorder. Bipolar disorder has traditionally been diagnosed only in adults, but in the last 15 years there's been an increase in diagnosis in children, including preschoolers. So one study reported a 40-fold increase in the number of children who were going to the physician's offices and they had a diagnosis of bipolar disorder, and there's been a corresponding increase in the use of antipsychotic medications and mood stabilisers in children and preschoolers as well. And this is very controversial both inside of psychiatry but also in the more general audiences. In the case of bipolar disorder in particular, the debate is complicated in a sort of an additional way. So in this case, we have not just the fact that different children receive different kinds of treatments, have access to different treatments and receive diagnoses under different circumstances from different practitioners, but we also have a fundamental debate about whether the diagnosis is even appropriate for the children who are receiving it. Recently, the task force from the American Psychiatric Association that's revising their Diagnostic and Statistical Manual, which is called DSM, they released for comment a revision or an addition to the manual that would try to capture some of the children who've been receiving the bipolar diagnosis over the last 15 years. And this they have renamed introduced the idea of a new diagnosis called temper dysregulation disorder with dysphoria, which they're calling TDD. And the idea is that children who were exhibiting outbursts, essentially, so rages, like very extreme and debilitating emotional outbursts followed by a lot of irritable mood, bad mood in between the outbursts, that those children would receive the diagnosis of TDD. And it doesn't say this in the diagnosis, but the impetus behind it has been to reclassify children as TDD who have previously been diagnosed as bipolar disorder. There really are a group of children who are extremely impaired by their mood and by their temper outbursts or their aggressive outbursts. So it's not a group of children who are functioning well, but the debate has really been about how to understand what is wrong with them and how best to treat it. Some commentators greeted the news of this suggested introduction of TDD into DSM 5 as a verdict on whether or not there really is this prevalent bipolar disorder in children. And they thought, well, now that TDD has been introduced, we can agree that bipolar disorder is actually very, very rare in children, and these children should have been getting this different diagnosis all along. And that may be, but the introduction of this new diagnosis won't resolve problems that all of the controversy around the diagnosis. So in a commentary that I wrote with my colleague Eric Perrins and Gabriel Carlson, who's a psychiatrist at Stony Brook, that's coming out in New England Journal of Medicine, we point out that even if children get this new diagnosis of TDD, there will remain a number of problems. And one of them is that we just don't have as many good, effective pharmacological treatments as we would like for these kinds of symptoms, and there is not necessarily the array of non-pharmacological approaches available for families who don't want to use medications or don't want to use medications only. So until we get serious about looking at the treatments that are available, developing new treatments and making good treatments available to people, we won't really have fixed the problem. So the good thing about the new diagnosis is it means that we are upfront about what we don't know, and it gives parents and families a much more realistic idea of the path that their child might be on. But there remain a lot of problems about the kind of healthcare system we've created and whether or not children can access suitable treatments, not just medication treatments, but also behavioural treatments, family therapy and other educational interventions. I'm Josephine Johnston. I'm a research scholar at the Hastings Center.